chronic myeloid leukemia, MPNs and things like that. But I think if I spoke to you about that, then you'd probably all definitely fall asleep after about 5 minutes. The whole point of today is to try and train you to become a hematologist so you can deal with the on-calls or the problems. So you don't call me at 2 o'clock in the morning. So we're going to try and make this as an interactive session as much as possible. And to do that, I need you to use your phones and to log into the website slido.com. We do have Wi-Fi here, so we'll be doing 3 cases. I'll be asking you some questions. It's all anonymous, so I'm not going to put anyone on the spot. But I'll come back to this just in case the benefit of time. So the first case is starting to think about, well, all of the cases really, is if you see any patient who presents with a fever, and especially if they're a hematology patient or if they're known to the team in hematology, what's the best next thing to do? Could this be infection? Could this be something else? So just remember that there's more than one cause for a fever in any patient. So we'll be looking at common things and not so common things. So the common things is probably stuff that you may end up seeing through A&E if you're a medic, all these kind of things, but equally not so common, but equally as important, because if you deal with them straight away, you potentially save their life, because these acute emergencies, if you don't deal with them within 24 hours, the mortality rate is very high. So this is the first case. So we have a 69-year-old woman. She's had very, very potent chemotherapy for high-grade B-cell lymphoma, and she's presented to the emergency department with diarrhea and severe ulceration in the mouth. All observations okay, blood pressure, hemodynamically stable, but she has a temperature. And as you'd expect 5-7 days after chemotherapy, especially this type of chemotherapy, she's neutropenic with a neutrophil count of 0.2. And CRP, which is mildly elevated at 34. So this is the first poll. So you can, if you join at slido.com, or you can just scan the QR code. What would you do next? Would you do a PR exam? Would you start C. diff therapy because she's got diarrhea? She's neutropenic, she's got a fever, there may be other things. Would you put an NG feeding tube down and start feeding through that route, or would you do a CT scan, or none of the above? So I can just give you a couple of seconds. We should see the results. So I agree. I mean, I would do a CT scan, because the risk of complications within the bowel, especially colitis, which is related to the neutropenia, is very high. And obviously this has risk in terms of perforation and various other things. So I think you can already start taking my job soon. So with regards to neutropenia, the first thing that I would say was that if the neutrophil count is less than 1, there's 2 major components in terms of what determines the risk of infection. One is the level of neutropenia. So we can see from this study to your right that the lower the neutrophil count, the higher the risk of infection. And that risk significantly increases once your neutrophil count falls to less than 0.5. The other thing as well is that there's patients out there who have ethnic neutropenia, so we may see it in the Middle East, Africa, sub-Saharan African patients, and within the sort of Mediterranean, where the neutrophil count is lower, but the total circulating neutrophils within other organs like the spleen and everywhere else is actually normal, and there may be an autoimmune component as well. And in these patients, it seems that the risk of infection is a lot lower if you compare, neutrophil count from someone who's just had chemotherapy to these kind of patients. Fever, we usually class as 38 degrees, seen in moderate to normal neutrophil counts as well. There are a whole range of different opportunistic infections that we need to think about in these kind of patients. So there are various different scenarios clinically as to what you may see. You may see a patient with a fever who's got clinical features of infection, and you've isolated the pathogen, so usually a positive blood culture, etc. You may see a patient with a fever and they've got no clinical features of infection. And then you may see patients who've got just a fever. And within the hematology world especially, the most common thing, it's very rare for us to pick up a positive blood culture or any other positive sign of a pathogen. You're dealing with a patient with a fever, maybe with a mild increase in CRP, what do you do? And really it's an art more than a science in these kind of patients. The number of neutrophils that you have, especially in patients who've had chemotherapy-induced neutropenia, their fever is not just because of infection. The neutrophils are very important in maintaining a competent immune system and maintaining that process where the body is essentially normal. And if the neutrophil count falls, then what happens is that you develop a pro-inflammatory process through various different chemicals and mediators in the absence of infection. So if you see a fever in these kind of patients, it's not always necessarily due to infection, but rather some sort of pro-inflammatory process. And also we know that the neutrophils are very important in maintaining the stability of especially the GI tract. So if you lose your neutrophil, your protection from the neutrophils, then pathogens are much easier to transverse through the GI tract and cause problems. Now in these patients, especially when they present with GI symptoms, you really have to have a thorough assessment of these patients. So look in their mouth, see if there's any ulceration, any bleeding, any breakdown. Assess in terms of other symptoms. Abdominal pain is always a worrying feature because we're worried that they may have perforated their bowel. Diarrhea is important as well. There's a whole range of supportive care. So in patients with really, really bad ulceration, they can't swallow, they can't eat. So you need to give them adequate analgesia and potentially think about nutritional support, ideally through NG tube if it's possible. If their GI tract is really, really bad, then you'd have to think about TPN. And then think about all the different infections that we could potentially see. So these are fungal infections like Candida, viral infections, and it's very important, even in the absence of a positive culture or clinical features of infection in these kind of patients, prompt intravenous broad-spectrum antibiotics is potentially life-saving. So these are the potential complications with regards to neutropenia and the GI tract. So neutropenic enterocolitis, which possibly this patient had, C. diff as well, especially in chronic cases of neutropenia. And then there's a whole range of other sorts of weird and wonderful bugs, which you may see in transplant patients. Like I said, supportive care is very important, and there's a whole range of things that we talked about. And if you see a patient, I think even if you've got a normal neutrophil count, but if they've got peritonism and they're systemically unwell, really you need to get that CT scan done urgently and seek a surgical opinion. Although surgery in these kind of patients is very risky as well because of the risk of poor wound healing and other complications as well. So that's the first case. We're going to go on to something which is a little bit more left field, I think, a bit more rare. So this is a 71-year-old woman. She has a history of tablet-controlled diabetes, hypertension, AF, and because of that she's on warfarin. She's presented with confusion and fever over the course of 2 to 3 days. She'd seen the GP, who treated her for a suspected urinary tract infection. But then 2 days later, after admission, she develops dense, probably Dr. Jaffa can help us here, dense hemiplegia and worsening consciousness. A CT head scan didn't show anything. And this is her blood count. So she's anemic, her white cell count is normal, her neutrophil count is normal, and her platelets are a little bit low. Importantly, her coagulation screen is normal. So what would you do next?
CT. Do you mean a normal INR?
Normal INR. Yeah. So remember, the patient has anemia, thrombocytopenia, normal white cell count. Coagulation screen is normal.
So she bled somewhere. She bled somewhere.
Well, the CT scan's normal, so Remember, this is the hematologist giving you the talk, so. I'm glad to say that you're not going to do a bone marrow there. So the correct answer is blood film. So if you have any abnormality in the blood count, the most important thing that you should do is a blood film, because the sample's already there, very easy to do, and that can give you a lot of information as to what's going on, and potentially life-saving as well. Let's have a look. So this is what the blood film showed. I don't know if anyone wants to...
I think this is urine, it's very much urine.
Anyone want to have a go, or they're not sure what they're looking at?
The MCV
Yeah.
here, obviously, and the shapes of the RBCs.
Yeah.
And that is why white blood cell.
Is that the atypical lymphocyte?
Hemolysing?
Sorry?
Hemolysing?
The what, sorry?
Hemolysing?
Hemolyzing? Yeah, very good. So what we have, so these, for people just to orientate themselves around this, because I assume you don't look at these on a day-to-day basis. This is a neutrophil, and all of these red, purple are all red cells. Now the normal red cell should look a bit like this. So it's got a nice, a red cell is biconcave in 3D. So if you look down at 2D, they'll have a hollow center. That just represents the biconcave shape. But these red cells don't all look like that. You have larger cells, like this, which is a little bit more purpley. So these are reticulocytes. These are immature red cells. The bone marrow is churning out these immature cells as a compensatory mechanism for anemia. So there's potentially some hemolysis going on. And then what you see is all these really weird and wonderful red cells. And these are what we call red cell fragments. So something's happening within the vasculature to, well, either blocking it or actually cutting them up and breaking them up. It's like cheese wire. So if you cut cheese through the very sharp wire, it'll just be completely destroyed. So what this basically suggests that there is some sort of stress anemia. The bone marrow, because of the reticulocytosis, is producing more red cells as a compensatory mechanism. You've got these red cell fragments, so there's something in there that's disrupting the red cell structure. There's thrombocytopenia, neurological signs, and a fever. So this should start making you thinking of something called microangiopathic hemolytic anemia, which is an umbrella term for a whole range of conditions like HUS, DIC, TTP. Very good. So the next step that we need to do really is look at the kidneys. Have they had a renal assessment? Because what's happening here is that there's a pro-inflammatory process. You're having microvascular occlusion, and because of that, they've had neurological symptoms. And one of the major organs which are very sensitive to blood flow disruption are the kidneys. So you want to see what the kidneys are doing and see if there's other features of hemolysis, like an increased bilirubin, direct Coombs tests, and LDH.
So is that Evans syndrome or not?
So this is TTP, so I'll come on to that now. So the whole point of this is abnormal blood count, blood film. Neurological features, thrombocytopenia, think of these kind of conditions. So like I said to you, this is, when you see this kind of picture, it could be due to a whole range of different things. And this is where you have to use your clinical acumen to decipher, is this DIC? Is this HUS? So it may be a child with a history of bloody diarrhea, and that can cause a similar sort of picture. Pregnancy can cause it, through preeclampsia, HELLP syndrome, etc. Severe infection, and solid, if you've got very, very advanced metastatic malignancies, can give you that kind of picture, because the pro-inflammatory process is making your vasculature very sticky, and because of that, the red cells don't like it, and it's breaking them all up. But as a hematologist, we're worried about something called TTP, or thrombocytopenic purpura. So this essentially basically means where you have an enzyme called ADAMS13. Now this is, it's one of the main players in the coagulation cascade. You have a protein called von Willebrand factor, and what that does is initiates your coagulation cascade. This enzyme breaks up von Willebrand into smaller multiples, which are functional, If that enzyme is disrupted, usually due to an autoantibody, or you could inherit a deficiency of this enzyme, your ADAMS13 are like the cheese wire. It stays like that. The red cells, because they're going through a high shear through the vasculature, they get broken up. Pro-inflammatory process occurs, and then you develop a fever, microvasculature, thrombocytopenia, and all the other sort of clinical problems that you have. So this is a medical emergency. If you don't treat these patients within about 2-3 days or so, 90% of them will die. If you treat them, their survival is very, very good. Over 80% of the patients, if not more, will live with no long-term issues. So classically it's thought that you have five main symptoms: fever, renal failure, thrombocytopenia, neurological signs, and you have this hemolytic process as well. But you can have any of these. You can have 1, 2, but you need to have a high index of suspicion. If you suspect anything like this, then really you need to call a hematologist, look at the blood film, and then decide, do we need to do further testing so you can test the level of this enzyme? And if it's low and it shows an inhibitor, the diagnosis is very straightforward. The treatment is plasma exchange, so you're removing the antibody and giving them normal antibody, but you're suppressing the immune system because you want to try and get rid of that antibody. So you give them high-dose steroids, and you can give them things like rituximab, and there's various other new drugs as well. So the learning point really is abnormal blood count, blood film.
Absolutely.
Yeah.
But what's the role of the imaging if they have a neurological signs?
Oh, definitely, yeah.
Yeah.
Definitely. I mean, an MRI, they probably need an MRI and various other things as well. But in these patients, we don't tend to see macrovascular obstruction. We see microvascular. That's the difference in here.
And the treatment reverse the neurological deficits?
Yeah, if it's treated early. Yeah.
Very good.
So that patient, we actually, was probably about 6 years ago now, and she was in the assessment unit just down the road in the Gwent. And she'd been on the ward for 3 days or so, and then she developed all these neurological features. So we managed to intervene quickly. So okay, so I don't know how we're doing for time. We're okay?
10 minutes.
Yeah. So this is the last case. So this is 51-year-old GP, previously well. It seems to be a poor prognostic sign being a GP, so after your story. He's presented with extreme fatigue, really abnormal liver function tests, high bilirubin, ALT, ALK-Phos, etc., and very high temperature out of the blue, from nowhere. You examine him, unremarkable apart from some mild jaundice, and his blood count is not normal. So he's anemic, he's leukopenic, neutropenic, and thrombocytopenic, so pancytopenia. His PT and APTT and INR are normal, but his fibrinogen is low at 0.9. You start him on IV tazocin, but he has no improvement in his fever after a couple of days. He's had blood cultures, all completely sterile. Do a CT scan, it shows some mild increase in his liver and spleen. Do a bone marrow, doesn't show any evidence of any cancer or malignancy or infection. Now he's getting worse. He's getting more confused, and he's looked like he's deteriorating rapidly as well. So, what tests would you do next to help you sleep at night? I think you could probably get away with 2 answers here. So I would go back and look at the bone marrow, and I would do a ferritin. Those are the 2 most important things. Why? Because you want to start looking for what we call hemophagocytosis. So this is where your macrophages, a key cell in the immune system, is starting to attack your normal blood cells. And this is what was seen in this patient. So you can see, this is a macrophage, which you don't usually see in the bone marrow. But it's starting to eat the red cells. You've got some platelets, and these are probably cellular fragments of other cells which we don't know. I'm not sure why I put that there. So what's happening is that in your body, you've got a balance between the good and the bad cells. Although you could probably say both of them are good. The macrophages are key in terms of driving your immune system when it sees some sort of immune response. Then you have, on the other side, things that control the macrophages, because you don't want to have an overactive immune system, because you get autoimmune diseases and various other things as well. So your NK cells and cytotoxic T cells, CD8 positive cells, they help dampen it down. They're like the brakes on the car. Now what can happen is that balance can get upset. So the macrophages have got no brakes on them, and they just go crazy. And that can result in various different things. So there may be some sort of trigger that's causing this imbalance of the immune system. So that could either be due to an autoimmune issue. So things like Still's disease can cause this kind of problem. Malignancies, various different viruses, and a lot of the time we don't actually know what causes it. In rare instances, especially in the pediatric setting, you may inherit a problem related to how your macrophages work as well. Either way, any of these issues, you get an uncontrolled immune system, you get inflammation within the body, so you get a massive increase in these really nasty chemicals in the body, TNF-alpha, interleukin-6, etc. And these all mediate tissue damage. So they can cause problems with your liver, and this is why we're seeing it in this patient. So real breakdown of normal organs and tissues, the CNS and the bone marrow as well. So this is a condition called hemophagocytic lymphocytosis, or HLH. And there are specific diagnostic criteria for this condition, which is set up by the HLH Society. So you need to either have a molecular diagnosis, so one of these inherited problems, or you have 5 of the 8 that you see below. Usually the inherited conditions are seen in the pediatric setting. So when I say a ferritin is actually very good at seeing whether someone has got HLH as well, because their ferritin is usually in the thousands, if not higher. It's a relatively straightforward test to do. But there's a whole range of other things that you could do, like lipid profile and more weird and wonderful tests as well. So like I said to you, there are a whole range of other things that can cause this and spark this off. So think of malignancy, rheumatological conditions, infections, and immunodeficiency as well. So really to sort of summarize is that if you see a patient with a fever, cytopenia, blood film, very important. And because these conditions can mimic other things as well and other drivers, clinical context is very important. Infection is very important, so prompt treatment with intravenous antibiotics is key. And think about really weird and wonderful things of immune dysregulation. And that's it for me. Thank you.
Thank you, Ali. If there is any question,
How often do you see such difficult cases?
So we probably see TTP once a year. HLH is probably about the same. Most of the cases of HLH that we see probably related to T-cell lymphomas. That's probably the biggest cause of it. I've done some pediatric hematology as well, and usually that's idiopathic, or it's usually related to an inherited issue.
But it also, if I may, please.
Of course, yeah.
Post-COVID, we had the pediatric multi-inflammatory systemic disease, where it mimics Kawasaki and toxic shock syndromes that I'm sure imagine, you know. And HLH, one of the differential diagnoses of this condition.
Yeah.
So we've seen it more compared to pre-COVID era.
Definitely. I mean, and COVID as well was implicated in some cases of TTP as well.
Yeah.
So there was, whether it was COVID, whether it was the vaccination,